I want to welcome you all. As you know, this is being webcast throughout Arizona. So just be aware, everybody in the room, people are listening to the audio from this and also seeing the live presentation, which we're very happy about today. And we are very excited that we were able to do this program in Arizona. It's taken about, I would say, 9 months to be able to present it today. So we're very happy that this is a program that the Tourette Syndrome Association from the Arizona chapter was very excited that there was funding available through the national, through a CDC funding, to do educational programming. And as you know, this is a continuing medical education meeting for professionals. And I just want to start out that I know we have a number of families here today, but this is really for our medical professionals. And we're going to do a Q&A at the very end, but the questions, we would prefer them to come from the medical community. We're doing a public family program after this that it will be more appropriate for the families. So on the cards, we'll talk about this. We tried to pass out the cards to write questions, and we will be picking them up at the end, sort of at break time, and we'll have a 30-minute Q&A session. We are also, at the webcast, people can email in questions, so we'll be taking questions also from people watching this elsewhere. So I just wanted to mention a few things. Again, this is the information that everybody is involved with on the webcast. You may know somebody out there that couldn't be here today. This webcast will be available for the next, say, 24 hours, that people can go on and listen to it to get continuing medical education. And it also will be maintained on the Department of Psychiatry's webcast program. It will not have continuing medical education, but it will be available on this same internet connection. So that's one of the things, it is going to be available for a while. I want to thank all the people that made this program possible, and it started out with the Program Planning Committee, and again the Department of Psychiatry, we went to them and they definitely stepped up and helped us. Also, Department of Pediatrics was involved. We had a few members from the Tourette board, and I'm Marty Fankhauser. I should have introduced myself. I guess everybody knows that I've been involved with this, but very much interested in getting a program from education. And then the CME committee also that approved the program. And again, this group had no conflict of interest. Dr. Walkup did want you to know that he is a consultant for Shire Pharmaceuticals, which does provide a medication that could be used in Tourette's, but he is only going to be doing peer-reviewed studies for his presentation. I want to tell you about the break. We made it a little bit too early. It will actually be at 2:30 today. We're going to go a little bit longer, so from 2:30 to 2:45, and then please come back, and we're going to be taking a 15-minute break. And for those of you here, you know we have refreshments in the back of the room, and we're sorry the webcast people will not get the refreshments. And then we will have a Q&A at the very end, so be sure and get your questions down on cards, and then we'll pick them up and Dr. Walkup will read them. So I'm not going to go over the learning objectives. There are quite a few that, again, we hope that this program will impact Arizona, will impact our education of professionals throughout the state, and again, even discussing things like developing a Tourette syndrome clinic through the Department of Psychiatry. We had discussions about this over lunchtime. And again, for the CME program, you must fill out the evaluation forms. We'll remind you again at break time. And Rachel Peterson, who is here, will be talking to you about that just before our break time, about how to get that information back in. And all of you here that are doing this program will ask you also to complete the evaluation for the Tourette Syndrome Association. So it is with great pleasure that we have Dr. John Walkup here today. He is, again, one of our outstanding psychiatrists in the country that has taken the lead on being very involved with Tourette syndrome. He has a very unique background, and I've asked that he actually do his own introduction because I thought it'd be better for him to describe what he's been doing and also his role on the Tourette Syndrome Association. So please help me welcome Dr. John Walkup.
Thanks, Marty. It's great to be here. I'm a child and adolescent psychiatrist. I did my medical training at University of Minnesota and then went to Yale to do my general psychiatry training in the Yale Child Study Center, which I think at the time I was there was the heart of Tourette knowledge, understanding, and research, and was very fortunate to be able to work with Donald Cohen and Jim Leckman. Jim's still with us and has a huge impact on the field still to this day. I left Yale and went to work at Johns Hopkins and worked there with Harvey Singer, who's also a Tourette expert, and so I've been able to work with lots and lots of folks with Tourette, experts in Tourette, and over time I've developed my own expertise. I've been the chair of the medical advisory board, believe it or not, over a decade, and one of the things I found out today that Judith Unger, who's retiring, she's the president and CEO of the Tourette syndrome. When she retires, I'll be the longest lasting person in the Tourette Syndrome Association. I mean, that probably some of you are too by your membership, but in terms of people who have an official role, I've been around a long time, and I'm looking forward to retiring myself. In the meantime, I'm very excited about talking about Tourette because we did a case conference this morning, and we had a wonderful lunch talking about a clinic and talked with some families about where we're headed, and we're headed in a different direction with Tourette. And part of what I know about change is to kind of create a vision. So many of you will have questions about whether we should go up or down on the Risperdal or whether the new form of clonidine works better than the other form of clonidine. But what I'm trying to do through today's seminar is really to change your vision about what Tourette syndrome is so that many of these questions, they'll have answers that may be true today but not true tomorrow. But your vision for the future about what Tourette syndrome is and where we're headed in terms of its treatment, that vision is really what the outcome of is today. And so you're going to get a lot more about philosophy than about dose, if you will. And you're going to get a lot more about envisioning kind of where we should be headed in the care and treatment of kids, teens, and adults with Tourette syndrome. So as long as everybody understands that, I think we're going to have a nice day. All right. So this is really the outline for the talk. I really do go through all of these different topics and talk a little bit about where we've been, but also about what we've done and where we're headed. So before I do anything, I want to talk a little bit about this guy. This is a self-portrait of a person that we took care of a while back, and I think it captures as well as any self-portrait the head and neck movements, if you will. But interesting about this guy is that he has a sad facial expression. And the treatment of this guy, when we saw him, the chief complaint was really bad Tourette syndrome. And I was very much interested in the sad facial expression. I said, well, what about the sadness? And the referring doc said, well, wouldn't you be sad if you had Tourette syndrome too? And I said, well, I've seen a lot of people with Tourette syndrome are some of the happiest people I've met. Why is this guy unhappy? And the doc said, well, you know, he's got a chronic neurologic disease that's not going to get better. And I said, well, okay. I buy that. So what have you done? Well, we want to get rid of his tics and that way make him happy. And I said, well, okay, well, that's a good plan for us to start our work. Let's do an evaluation. Well, this person was 16 years old when he presented, 15, 16. Your tics aren't supposed to be getting worse at 15 or 16. They're supposed to be getting better at 15 or 16. So something took this guy's normal course of illness and made it worse at 15 or 16. So as we took the history even closer, we identified the fact that this boy, about 6 months before his tics started worsening, he started appearing sadder. He didn't sleep as well, wasn't eating as well, was more cranky and irritable, and met actually criteria for a major depressive episode actually before his tics got worse. We know that the outside stresses and strains can make Tourette syndrome worse, but we also know that internal dysregulation of mood and emotion, so anxiety, upset, unhappiness, can also make tics worse. This guy was treated with tic-suppressing medicines, and we know from research by Ruth Bruin that was done probably over 20 years ago is that some of those medicines actually worsen mood and worsen anxiety. So what we saw with this guy is he had a tic disorder. He was treated with tic-suppressing medicines. His mood actually got worse on those medicines. The worse mood increased the severity of his tics, went up on a higher dose of tic-suppressing medicine, worsened his mood, went up on his tics. When we met the family, we said we really want to take him down off his tic-suppressing medicine because we think it's contributing to his tic severity. They looked at us like we were completely nuts. The treatment that's supposed to work for him, that's not working, you're going to get rid of that, it's only going to get worse, isn't it, doctor? Well, tried to explain that what we were doing was getting out of this cycle of giving a medicine that we thought would be helpful, having it contribute to depression, and depression contributing to tic severity. We actually treated this boy with antidepressants. We treated his mood disorder. And over a 4 to 6 week period, his mood improved and his tics went back to their baseline level. So I think it's important, and the only reason I show this slide in the beginning is when we're thinking about kids with Tourette, the tics are such a prominent feature of the condition, but we have to remember that the action is with those other conditions. And try as you may to kind of discipline yourself to not focus on the tics. It's so tempting when the tics present themselves, especially when they're in the moderate to severe range, to get overly focused on the tics and get caught up in a pattern of what I call chasing tics with treatments that oftentimes don't work or cause weight gain or sedation, when indeed there are other targets of treatment that do much, much better with our conventional treatments, and kids can have much better outcomes. So remember, tics are important, not saying they're not, but it's that other stuff, the other important stuff that we need to pay attention to too. All right, so what's in a name? This is him. This is Guy de la Tourette. So it's been called Guy de la Tourette syndrome, Tourette's syndrome with an apostrophe S. And in the diagnostic manuals, it's Tourette's disorder. It's all the same thing. There have been slight changes in the diagnostic criteria over time, but it's pretty much the same thing. What's it take? Well, for TS, you have to have motor and vocal tics. You have to have it for a year. I don't have this on the slide, but it has to start before age 18. And there's always been a debate about whether you have to be impaired by it or not. And recently, the previous diagnostic manual, they took out the requirement for impairment. Paul DeVore, who's a good friend, chairman of the board of the trustees of the Tourette Syndrome Association, has, I think he has a video on the website, has, moderate Tourette. And he was so happy when they put the impairment criteria in because he said he didn't have Tourette anymore because he wasn't impaired. He's an investment banker and does pretty well in this world. So he met all the other criteria, but because he wasn't impaired, he didn't have Tourette, and he was very happy that he didn't have Tourette anymore. 2/3 of people are self-diagnosed, and I actually think it's probably climbing. We're moving up probably into 75%. We don't have any good data on that. But most people, when they see their youngster ticking, they go to the internet nowadays, and they look it up or they talk to a neighbor. Somebody knows about Tourette syndrome nowadays and points them into some website somewhere. Hopefully they go to the Tourette Syndrome Association website, but a lot of people are going to doctors to get the confirmation. And it's not unusual for people who have self-diagnosed to go to the doctor and find that they've actually read more about Tourette syndrome on the internet than the doctor ever learned in medical school or in residency training. So part of the reason why we're doing these symposia is really to get everybody up to speed so at least we all know what's on the internet. Chronic motor or vocal tic disorder, it's motor or vocal tics for more than a year, and again before age 18 onset. And we have just a couple of new things in the latest proposal for diagnosis. It used to be that if you had your first tic at age 6 and you only had tics from age 6 to 7 for 6 months, that you wouldn't be given a Tourette syndrome diagnosis. You'd be given a transient tic disorder diagnosis. But let's say between 7 and 8 you had tics again for about 6 months, and you had 6 months off. And then the following year you had tics again for 6 months and had 6 months off. You would be given a diagnosis of transient tic recurrent. Now, most docs who I interviewed about this said, well, if you had them at 6, you had them at 7, you had them at 8, you got chronic tic disorder. I don't care how many months you've had off, you've got a chronic tic disorder. So what we did is we got rid of that idea that you had to have it for more than 9 of 12 months in any given year. And so now what it is if you've had tics, no matter how much time you've had when you haven't had tics, if you've had tics for more than a year since the very first tic, then you qualify for a chronic tic diagnosis, either Tourette syndrome or chronic motor or vocal tic. We also got rid of transient tic disorder because if you think about it, in order to get a transient diagnosis, you have to have had tics and had them go away, right? So if a kid comes in and he's got tics now and he's only had them for 6 months since first tic onset, you couldn't call them transient because you're not going to know that they're transient until they go away 6 months later, right? So transient was like a bad word. So provisional is not a whole lot better. But now when kids come in, and kids are coming in a lot like this with 3-month histories, 4-month histories, 5-month histories of tics, they haven't really had symptoms for a year yet. They don't qualify for a chronic diagnosis. What we do is we say they have a provisional diagnosis of a tic disorder. So that we're waiting a little bit more time to see whether the tics stay around or whether they actually leave. Little history. Tourette was working back in the late 1800s with Charcot, and right around the corner was this fellow named Freud. And Charcot was a neurologist working on neurologic diseases, and he and Tourette identified this small group of patients who made sounds and had unusual movements and looked really different than all of the other movement disorders that Charcot was working on. And so Charcot told Tourette, why don't you write them up, you know, classic medical kind of thing, put your name on it, and we'll see whether the scientific community buys what we're selling here. And we did. And so it became Tourette syndrome in the late 1800s. The problem was at that time there were no treatments for any neurologic diseases. But this Freud guy was essentially working on people who had hysterical symptoms. So a hysterical inability to use the arm, meaning that there wasn't an organic reason for it. It was a psychological disturbance about using an arm, or hysterical blindness. There are some people who lose their voice in a hysterical way. When I go to my optometrist and I remind him I'm a child psychiatrist, he tells me how much blindness he has cured. The rates of blindness go up before final exam time in junior high school and high school. And right? So my optometrist cures blindness, and so did Freud. So all the patients who had these interesting complicated syndromes that neurology didn't have treatment for, they all went to see Freud and Freud's colleagues. And it stuck with Freud and Freud's colleagues until 1965. So a period of time of about 75 years, this condition was really understood as having a psychological cause to it. Well, what happened in 1965? Well, antipsychotic medications had been out probably for about 15 years. And anytime a doctor has a medication that works for anything, they begin to try it on everything else. And so that's what happened. So they had a medicine that worked for severe psychotic symptoms, and so they tried it in patients with Tourette syndrome, probably some of the more disabled patients, and lo and behold, it decreased tic severity. And pretty much overnight, there was a change from this being a psychological condition to a neurological condition. And the cool part about that is it takes all the stigma away. This isn't something about, you know, how you manage your psychological material, but this is really about a brain problem that you're probably born with, that you can help, and that we now have treatments for. With this came a huge surge in research, lots of people getting treated. In 1965, thereabouts, there are 100 cases reported in the world literature. Now we're estimating the prevalence to be about 1 in 100 in school-age kids. Oliver Sacks, famous neurologist and author, wrote many books about, as soon as he learned about Tourette syndrome, he walked through the subways of New York and on the streets of New York, and he could pick up a case in almost every block. Many people lived with the tics without necessarily being affected by them, and the condition was probably much more prevalent than anybody ever thought, but it was only at the milder end of the spectrum. The other thing that people noticed as they began to see more cases is that, if Junior has it and they look at mom and dad, either mom has it or dad has it. And so they said, oh my goodness, we have a condition now that affects children, but one or both of their parents actually have something like it too. And if you ask their parents about it, they'll describe one of their parents who had something. Well, when doctors hear about a condition that is passed from one generation to the next, that is a pattern of inheritance called autosomal dominant. And that autosomal dominant condition came out, that paper came out in, I think, 1983 from the Yale group. That all of a sudden meant that, we have a gene that's going to be really easy to find. Well, we've been looking now for a while. It's probably more complicated than we thought. But one of the byproducts of that hunt for the gene that started in the mid-1980s is we began to appreciate that within families of people who tic, there's a higher rate of ADHD, there's a higher rate of anxiety, there's a higher rate of obsessive compulsive disorder. So we've begun to understand that, yes, it's not a psychological condition, and it's really a neurologic condition, but that neurologic condition has as complications psychiatric disorders, brain-based psychiatric disorders like ADHD and OCD. The other thing that we began to do is we began to study the patients more closely. And so we were involved in some twin studies. And wouldn't you expect that identical twins who have the same genetic material, wouldn't you expect that their Tourette syndrome would look a lot alike? You would, you should, it doesn't. So there was a marked difference in severity between twins, even though they had exactly the same genetic material. That told us that even though it may be a genetic disorder, your level of severity may actually be more determined by environmental factors than actually by the genetics themselves. So one of the findings early on was that in those identical twins, the lower birth weight twin, the one who maybe didn't get as much food or nutrition in utero, that one's tic symptoms were worse than the higher birth weight twin. So that difference in intrauterine environment may have been enough of an environmental factor to shift the severity of the tic. With the advent of behavioral treatments, so strategies that we can teach adults and kids to manage their tics, we now are thinking about tics in a completely different way from an environmental point of view, and that is the environmental factors can make tics better, can make tics worse, but by manipulating the environment, we can actually teach kids how to manage and adults how to manage their tics more effectively. So we are now thinking about Tourette syndrome as a neurologic disorder, commonly complicated by psychiatric conditions, that can be managed with behavioral strategies. This is a very complicated way of looking at it. If you do the reverse, we were talking a little bit about this at lunch, this is a condition now that on first identification, we ought to be thinking about behavior and functional approaches right off the bat. And the people who first see kids with tics should know this, and they should be intervening early, thinking about those behavioral and functional strategies to help kids and families work at managing tics more effectively. I'm going to talk a little bit about that at the end, but that's where we're headed. So I hope you've got the vision. Neurologic condition, no question. Complicated by neuropsychiatric disorders, which oftentimes make it are the most difficult and challenging aspects of the condition, but that we can do a lot early by thinking about behavioral and functional approaches to improving outcome. Okay, like I said, the prevalence rate depends upon age. About 20% of kids will tic in grade school. 1 in 100 will actually have a Tourette diagnosis. 1 in 1,000 maybe in adulthood. What's changed really? Awareness has changed. The fact that you have a treatment for something, that makes it easier for people to make the diagnosis. And the diagnosis now includes people who aren't impaired by their condition. Very few kids in a year will actually pursue treatment and get a diagnosis. Some of that's because of under-recognition, but some of that is because not everybody who tics actually needs a treatment specific for their tic disorder. Some folks have mild enough symptoms that they can live pretty well without it. Is it inherited? Well, I talked a little bit about twin studies. Yep, it's inherited, absolutely. And I think we've been looking for what the pattern is. This is going to be a multi-gene, complicated condition. And the Tourette Syndrome Association International Consortium of Genetics is doing a nice job working on that. There's now a couple of groups working together to think about what the genetic underpinnings are of this condition. And I think a lot of our inability to find the gene is not because people are working hard. I think people are working extremely hard because the prize to be able to understand the genetics is going to be a big one. But it really is our technology and our capacity to actually study these complicated diseases and to sort it all out. They're looking for sample sizes of 6,000 people just in order to run preliminary analyses. That's a lot of research subjects, if you will, who have donated blood or spit, if you will, to these studies. I get the question, got it today. My kid's going to have kids. What's the risk and what do we say? So I think that question really misses a very, very important point. What I want to, the question I rephrase is, what info can you give me that prepares me for having a child with Tourette? That's very different than should I have a child and what would happen if they got Tourette. So this isn't meant as genetic counseling information, but it is kind of an important way, again, visualizing how we think about this condition so that people can make good decisions. So most kids do well tic-wise by the time they're in their 20s. Actually, they begin to improve in their late teenage years. The genetic risk for TS is not the same as the risk for poor lifelong outcome. Again, we were talking about it over lunch. We hear about kids who are really struggling, and families will say over and over again, you know, it's really not the tics. It's really not the tics. But somehow we get locked in. Maybe it's because the tics are such a salient feature of the condition. We get locked in on the tic part of this real early and very hard, and we kind of lose track that there are other problems that actually are potentially more disabling than the tics themselves. What are the important risks? Well, the tics, yes, but those co-occurring conditions are really, really important. And there's a variety of things that also impact outcome, and I'll talk about those in a little bit. So what's the risk to relatives? So if your son or daughter has Tourette syndrome, the risk to their kids is somewhere between 15% and 35%. But remember, there's a wide range of outcomes. 20% of kids will tic or twitch in grade school and not go on to develop Tourette syndrome or a chronic tic disorder. So they could have the genetic material but not necessarily be severe. Most of the outcomes for tics are good. Most people have mild to moderate symptoms. What you see on television is not a real replication, or now on YouTube. Looking at some of the Tourette syndrome stories on YouTube, those are not your average ordinary case. Those are oftentimes the more severe cases, the more disabled cases. Peak is at the early teen years. And I think the other piece is that if you talk to people who are 50 or 60 with Tourette syndrome and what life was like for them growing up, and you look at how we treat kids now who are 6 to 10 with Tourette syndrome, they're living in a completely different environment. While we haven't done everything we can to reduce the stigma for Tourette is much less now, and we have many powerful tools to affect the impressions of others and to advocate for kids with tics. So what do I look at when I worry about long term? I look in the family history for ADHD and learning disabilities. I look in the family history for OCD and other anxiety disorders. I look for depression and bipolar disorder in the families of kids who have tics, and I also look for substance use disorders. Those disorders have the capacity to ruin a life if they're not identified early and treated. So if you have a kid who's got tics and he has genetic risk for these conditions because of a strong family history in one way or another, as the treater, I want to know about that family risk and make sure that I'm doing advanced watching, that I'm doing anticipatory guidance, and screening all through that young child's life during those key developmental periods so that I'm not the last to know they're having a mood disorder. I'm the first one to suspect that there might be one there. That's my job as a clinician who has expertise about Tourette, is not to worry too much about Tourette, but to think about the other conditions that unfold over the child's lifetime. Oh, and one more thing. I don't think I'm going to have to tell this audience, but kids with Tourette are hard to parent. Yeah, and we've kind of bought into a style of parenting in the United States where we parent out of our heart and out of our gut. We don't parent too much out of our head anymore. We parent with emotion. And the problem with parenting with emotion is that we parent in a reactive way. We do not parent in a proactive way. And one of the challenges of parenting, one of the problems with parenting in a reactive way is we get into interactional struggles with our kids. And those interactional struggles actually don't work very well over the long term, either for parenting practices or for kids' longer term outcomes. And the last part of today's lecture, I'm going to talk a little bit more about that aspect of it. But I worry more about family history of other psychiatric disorders and current parenting practices than almost anything else in my clinic. Because if I can anticipate those comorbid conditions and intervene early or prevent, and if I can train mom and dad up to a style of parenting that doesn't inadvertently get them caught into cycles of interaction that create maladaptive behaviors or worsen tics inadvertently, I know that this is a family that's going to be on a smoother path moving forward. All right, so what's the risk for poor lifelong outcome? Well, less than 10% of people have severe tics moving into adulthood. On the other hand, the prevalence rates of depression and anxiety and these other conditions actually increases as people move from adolescence into young adulthood. It's interesting, if you meet people who have been successful with Tourette syndrome, their tics oftentimes don't dictate kind of how successful they are. It is really their life adaptation and coping. So Peter Hollenbeck, who is the former co-chair of the Tourette Syndrome Scientific Advisory Board, Peter's a professor of neuroscience at Purdue. He's got a couple of kids. His daughter, I think, got all the scientific genes. She's going to have a fabulous scientific career. This is a guy who's got Tourette syndrome. And it's pretty obvious to anybody who meets him that he's got Tourette syndrome. But he's had a highly successful professional and personal life. And so it tells you that on some level, while the tics can be moderate to severe, the action is really someplace else. And trying to make more Peter Hollenbecks or Paul DeVores is really what we're all about. And that requires not just focusing on the tics, but focusing on those other things that make people successful. So poor coping and self-control skills, those are big. And those are things that moms and dads and clinicians can do a lot about. Okay, so from a genetics point of view, I don't worry too much about the genetics of tics. I worry about the genetics of those comorbid conditions, and I also worry about kind of how families live together, decisions they make, how they parent, because those are the things that have longer-term impact. Course of Tourette syndrome. Well, it starts in young kids. And average age of onset is about 6, 7, something like that. That's period of diagnosis. Some kids, we've seen kids at 2 or 3. Oftentimes those really young kids have stereotypic movements, which really aren't tics. Tics more often start at 4, 5, and 6, get diagnosed at about 7. They peak in severity probably 13, 14, 15. A lot of people think that Tourette syndrome is a pubertal disease, so that these are kids who get worse during puberty. What's interesting is the tics actually get worse before puberty, although puberty is happening earlier and earlier, and gets better right about the time early puberty. What gets worse around puberty time is really the mood disorder stuff, depression. Anxiety gets worse between 6 and 10. Depression starts getting worse. If it's going to present early, it's going to present in the 13, 14, 15 age range. A little bit like that self-portrait I showed earlier. And then the comorbid conditions, ADHD starts before the tics oftentimes. Anxiety disorders start about the same time, 6 to 10. But all the rest starts later. So Depression starts later, bipolar disorder starts later. Those conditions oftentimes occur afterwards. So what this gives you is this kind of evolution. So you'll see in the history youngsters who have ADHD symptoms first, then they go on to develop tics, starting with motor, going to vocal, starting simple, going to complex, beginning up here and moving down into the extended part of the body. OCD and anxiety sometimes presents itself slightly later or continuous with the onset of tics. Depression unfolds in the teenage years. And then behavior and coping problems really can develop after that as people try and become independent livers, if you will, dealing with their life on their own. And so as a person who cares for patients with Tourette and as family members who work with them, you have to be aware that, just because you see a tic at age 6 or 7, that's not the sole focus over the course of development. We have to have a developmental understanding of the unfolding of these symptoms and challenges over time. What are the co-occurring problems? Well, almost everything has been described as part of Tourette. And there are times where I think about Tourette as a kind of a basket case diagnosis where you take every problem and you just kind of dump it in. In order to belong to that basket, though, you have to have the motor or vocal tics. So how do you sort this all out? So this is what we actually do in our clinic. The most important thing for people to understand is when I see a kid in my clinic, I assume that they have tics, they have ADHD, and they have OCD diagnoses. I wouldn't be seeing them if they didn't have those three. And the trick, if there is a trick, is that there's a fourth condition. And so what I'm looking for when I see a kid in my consultation clinic is I spend about 30 seconds on the tics. I spend probably another 30 seconds on the ADHD. I spend a minute on the anxiety because I think that that's an important one. But then I'm looking for the condition that the 3 previous doctors didn't get. Because that's why they're coming to see me. They've been looking for the final answer or some kind of summary explanation that brings it all together. So the conditions in red are conditions that present prior to puberty. So separation anxiety, generalized anxiety, social anxiety, those present between 6 and 10. Pervasive developmental disorders, we see a lot of Asperger's in our tic and OCD clinic. I actually joke that we see more Asperger's in our TS and OCD clinic than they see in the Asperger's clinic. The reason is the kids with Asperger's have repetitive behaviors. And they also make funny movements, stereotypies. And so the docs who see them are often confused about it. They send them to us, is this Tourette's? Because he's got repetitive behaviors, he makes movements. Is this TS and OCD? And nope, we say, no, this is Asperger's, and those are stereotypic behaviors and perseverative behaviors, and they belong to a different group. Believe it or not, children with Tourette can be naughty. Teenagers can get depressed. Late teenagers can develop bipolar disorder. For me, the dirty secret about Tourette syndrome is the risk for substance abuse. We do not talk about it much, but there is something about having Tourette that makes alcohol taste better and that makes marijuana dreamy. These kids will describe smoking marijuana or taking a drink of alcohol and just feeling that level of arousal just drop. It makes them extremely comfortable short term. And as a result, they abuse. So one of the things for people who take care of adults with Tourette syndrome need to understand is that this is a disorder that probably has a slightly higher risk for addiction. And evaluating people for that problem is something that's important. And then lastly, there are people with all kinds of personalities, right? Easy personalities, difficult personalities. Well, Tourette syndrome people are the same way. Some people have easy personalities. Those folks are easy to treat, easy to help, easy to provide guidance to. And then there's some people who have more complicated personalities whose personalities may be more difficult to manage actually than their Tourette syndrome. And so from a clinical point of view, sometimes you have to adjust expectations for outcome, not so much because of their Tourette syndrome, but because they have the capacity to make bad choices or not cooperate with care or not follow through with directions that will actually cause them lifelong troubles in a way that's different than what you would see with just Tourette syndrome. We also see a lot of symptom confusion. Oh my goodness. You know what psychiatry is? Psychiatry is a study of behaviors that happen too much or too little. Just think about it. Too much or too little. So we have a variety of repetitive behaviors, right? Tics are repetitive behaviors. Within a patient, they look fairly similar. But then we have this thing called compulsions. Well, that's a repetitive behavior too, but it's kind of different than a tic. It looks more purposeful. But there are some tics that look more purposeful, like they're hopping or twirling. Is that a compulsion or is that a tic? And then you see kids with developmental disorders have stereotypies, repetitive movements like this, or repetitive movements like this, or arching, or movements like that you see kids do. Those are repetitive movements too. We see people perseverate. These are behaviors you see people do over and over again. So in more impaired individuals with autism, they love spinning. So they'll turn a trike on its side and spin the wheel and just watch the wheel spin for extended periods of time, or they'll do a puzzle, dump it, do it again, dump it, do it again, dump it, and they can do it for 3 or 4 hours at a time, that repetitive behavior. That is not a compulsion and that is not a tic, but it is a repetitive behavior. So that's why we see the Asperger's kids coming into our clinic, is that people don't necessarily think about using the right term for the right phenomena. And if they don't use the right term for the right phenomena, then you begin to pass on into different pathways of assessment and treatment. That kid who is using marijuana compulsively is addicted. We use addiction for that as opposed to compulsive. We've had kids come into our clinic, our OCD clinic, with compulsive marijuana use. And they want to avail themselves of the kinds of treatments that we would use for OCD. They need drug treatment. They don't need OCD treatment. We see people with habits or mannerisms too. We have repetitive thoughts in psychiatry. So we have people who are obsessed. These are intrusive thoughts that are silly, make no sense. I talked with a dad the other day who said, when I was younger, I would look at my left hand and I would think it was my right hand. And I'd look at my right hand and I was thinking it was my left. It was the strangest thing. And whenever I thought about, somebody said, raise your left hand, I would go, because he had doubt or confusion about what his left or right was. He knew it was completely silly. It was intrusive in his mind. He couldn't kind of get rid of it. The more he fought it, the more it actually got worse. That's an obsessional thought. Intrusive, unwanted, and silly. That's very different than what we see with tics, with that premonitory sensation, where we have this sensation in the shoulder that's an itch or a tug or a hot sensation, and we do something with the tic to kind of make it go away. That kind of feeling doesn't oftentimes have confusion, doubt, worry. It doesn't have an affective charge to it, if you will. It's not a strong emotional symptom. It's much more of a physical sensation, discomfort kind of symptom. So that's what we would call a premonitory sensation. Ruminations are recurrent thoughts, but those are the kinds of things that we see in people with depression, and there's some classic ones: bowel disease, brain disease, and poverty. So when I hear about a teenager who is worrying about poverty or that their brain is rotting from the inside out, I don't worry about OCD, I worry about very severe depression. It's the kind of classic symptoms that psychiatrists see in 40, 50, and 60-year-old adults. They will come in, they'll show you the checkbook and they say, I'm worried about running out of money and being put out on the street. And you look at the checkbook and you hear the balance from the children, and it's like, their husband died a while back and they have gazillion million dollars in the bank. Poverty's not an issue, and if it was, the kid's got enough money to take care of them. But they look in the checkbook and they're worried about poverty. Or they're worried that their brain has stopped working, or that they have cancer of their bowel. Those are very common ruminative ideas that you see in people with depression. Perseverative thoughts are what you see in autism and PDD and other brain damage, kids with brain damage. These are things they get stuck on. OCD intrudes. People get stuck on perseverative ideas. So you'll see the kid, very famous kid that I saw when I was in training in the center that I worked. He had a thing about tall. Who's taller, you or your mom? Are you taller than she is? Is she taller than you are? Are you taller than that lady? That was it. Oh, you're pretty tall. You're taller than me. That was all this kid talked about was tall. Well, that's a perseverative thought. If you were thinking about treating that with like a compulsion, you would probably be barking up the wrong treatment tree and not necessarily get the same kind of outcome. So using the right word for the right phenomena is really important. And one of the things that we've done is we've kind of made everything compulsive. So right now, all of these repetitive behaviors sit under a compulsive moniker, which makes it very difficult for us to sift and sort and make good diagnostic decisions. That wanting to smoke marijuana all the time, we call that a craving. Goes with addiction. Overvalued idea is one of my favorite ideas in psychiatry, or concepts. What's an overvalued idea? An overvalued idea is an idea that is very common in the community, but it has become overvalued. So in New York City, it's very, very important to be thin and beautiful. But you take that to the point where you lose 30% of your body weight and you don't eat anymore, and you're beginning to get osteoporosis at age 17, that's anorexia nervosa. Now, some people will call that compulsive, so they have a compulsive need to not eat or compulsive exercise. This is all driven by an overvalued idea. Most of the kids I've seen with anorexia have been treated like they have OCD, and they don't benefit from OCD-style treatments. So understanding it's not compulsive in quite the same way that OCD is compulsive, understanding that these are really overvalued ideas and that you oftentimes use behavioral treatments, you're going to be in a much better place. I've worked in cities where there's been a lot of kids who get banged up, traumatized, have horrible life experiences. When they have intrusive thoughts, it's often intrusive thoughts of the traumatic experience. We call those flashbacks. So very important, when you're evaluating a kid and they say, I have compulsions or obsessions, you want to know exactly what the content of those are, because it makes a huge difference in terms of what your diagnosis is going to be and what your treatment's going to be. I do want to talk a little bit about anxiety disorders, because I think this is one of the conditions that is missed most frequently in young kids. And not OCD, it's really these other three. So, anxiety disorders, physical complaints. Why do kids with anxiety have physical complaints? Well, a couple of characteristics of people who are anxious. Are you ready? Three big ones. They are hypervigilant. They are chronically scanning the environment, looking. They are reactive to novel stimuli, so anything new in the environment they lock onto. And then the third and important component is they view it through a threat bias. That means they're scanning the environment, they're looking for something new, and when they see something new, it's bad. Right? So that's what anxious folks do. And if you know anybody who's anxious, that's what it's like to live with them. You're hanging out with them and they're like, did you see that? No, what? I didn't see that. No, did you see that? What are you? And they move on to the kind of the worry about it. Well, anxious kids do that to their body. Do you know how our bodies gurgle and burp and ring and buzz, and our knees and our joints, they make? Well, anxious kids listen to their body and really react to that with that threat bias. I'm probably going to die, something terrible is happening, what am I going to do? So as a result of that, they have more complaints about headache, they have stomach aches, bowel problems, they're sick in the morning and can't fall asleep at night. These are kids who wake up in the morning nauseous, have trouble falling asleep at night because they're worried about waking up the next morning feeling nauseous, or about how they felt nauseous that day when they woke up in the morning. These are kids who frequently urinate or defecate. So when I talk to teachers, I say, well, how many of you have a kid who before every test has to go to the bathroom? And they say, well, yeah, I have 4 of them in my class. I send them out as a troop, make sure none of them get lost. I don't know if they're anxious kids, but my betting would be that, yeah, they may have some anxious stuff going on there. These kids get short of breath. They get chest pain and tachycardia. The heart rate beats fast. They have a very sensitive gag reflex. They have fear of choking or vomiting. And oh, by the way, for the pediatricians, the group of kids who can't swallow pills between ages 6 and 10. Think about anxiety with that population. It is extremely common. Difficulty swallowing foods. Anxious kids are actually smaller than other kids. They probably don't thrive very well. May have something to do with appetite, may have something to do with sleep disruption. Sleep is when growth hormone is secreted, and if you're not sleeping soundly through the night, and anxious kids don't sleep soundly through the night, could have some disruption. But when you meet these kids, they really, from a psychological and well-being point of view, are not thriving. So part of that thriving is on the psychological level, and some of it looks like it's also involved with growth. Let me go back. So the way I think about anxiety now, I think about it as a midline physical disease. They have trouble swallowing. That lump in the throat that we oftentimes get, anxious kids don't have a lump in there, they've got a softball in there. It's there all the time. Makes it very difficult for them to swallow pills, to talk sometimes, to chew solid foods. They get respiratory problems, so they get short of breath. They have hearts that beat faster or have chest pain. They have stomach upset more readily. They've got bowel and bladder conditions. So if you think about that set of physical symptoms, and you see those in a kid starting at between ages 6 and 8, or 6 and 10, those are symptoms that are commonly seen in anxious kids presenting during that period of time. It's extremely common. Probably upwards of 8% of kids will have an anxiety disorder. So, and when I do this talk in front of a Tourette group, they go, oh my God, my kid had all of those. I mean, he's just a real stickler right up and down here. He's got all kinds of that stuff. And I said, well, what's he been diagnosed with? He's been diagnosed with Tourette and ADHD. I said, oh, I bet it's the inattentive subtype of ADHD. He can't pay attention, right, but he's not hyperactive. Oh, yeah, he's just inattentive. I said, well, if you're worried about this part of your body 24/7, it's going to be very difficult for you to sit in classroom and pay attention to what the teacher is working on. They get dizzy and lightheaded, but I don't hear that too much. Anxious kids are exhausted at the end of the day. When I came home from school, I was a little anxious, but when I came home from school, we ran out and played. We had so much steam to blow off. We had so much energy to get rid of. We were looking forward to that free time to really just let it loose. Anxious kids come home and take to bed. They've had a very trying day. It's been very difficult for them. And they've been managing their anxiety all day long. They are completely exhausted at the end of the day and do take to bed. Some of that irritability and explosiveness that you see after school in some of the kids with Tourette, that's anxiety related. Because all of a sudden you're expecting them to do homework, and what they need to do is they need to rest and recuperate from the demanding day. Derealization and depersonalization, these are fun symptoms. When you've been in kind of like a near-miss car accident and your head is kind of wobbly and you're breathing and you feel kind of, oh my gosh, what is that? Your arms are kind of rubbery. That's derealization. That's like the world is not real anymore. You don't feel comfortable. Just think if you're 8 years old and you're trying to describe that sensation to a parent. They think you're crazy. Let's say you have Asperger's and you try and describe derealization. Oh my goodness, that is really complicated. Depersonalization is the experience you have when you're talking with somebody at a party and then you spill something on them and you take one step outside of yourself and you say, boy, you are a clumsy idiot. And you kind of look at yourself and you berate yourself, and sometimes you may talk back, don't be so hard on me, it was just a mistake. That's depersonalization, when you kind of split yourself into two. Well, again, just think if you're 8 years old and you're trying to describe that, you're going to sound pretty nutty. So we see anxious kids get diagnosed with psychosis because they have these kinds of experience and their language and conceptual abilities are not great enough to actually communicate. So when you're listening to a kid talk about this stuff, you have to have a perfected ear, if you will, to be actually able to hear these symptoms kind of through their language difficulties. And then the crippler. This is the real crippler among anxious and anxiety, and that is avoidance behavior. So anytime any kid has had any one of these symptoms in any setting whatsoever, Remember hypervigilance, reactive to novel stimuli, and threat bias. Anytime they've made a conclusion that something is dangerous, the next time it's presented to them, they will do anything to avoid. And one of the problems with avoidance is that nowadays parents are very keen on supporting avoidance to decrease kids' stress. So what we're seeing among kids and their parents with anxiety disorders is a conspiracy of avoidance. And the problem for me with avoidance behavior is that over time, all of your adaptation and coping skills are developed by accident through the course of development. You do something, you make a mistake, you figure it out. You do something, you make a mistake, you figure it out. You do something, you make a mistake, you figure it out. If you do something, it's uncomfortable for you, and then you avoid it for the rest of your development, there's no growth there. To get strong, you got to push more weight, right? To run longer distances, you got to do training to get stronger to run longer distances. To have a rich, robust adaptation and coping mechanism, you have to have a lot of mistakes in your life. You got to try a lot of different things. You got to go a lot of different places. You got to meet a lot of different people. You've got to try and succeed, try and succeed, try and fail, then succeed. And if you're avoiding all the time, it's not going to happen. So we work very hard with moms and dads to set up a kind of a no-fear environment within the home. Yeah, no, I know you're uncomfortable, but let's do it anyway. Oh, yeah, okay, you can do this. We'll figure out a way to get it done. Oh, not a problem. Yeah, no, I hear the apprehension, but we're not going to let that get in our way. That, for me, the Nike swoosh just do it thing, is the mantra of parents that parents need for anxious kids, but for kids in general. We've gotten to be very protective of our children for some good reasons, but once it gets too much in that overprotective way, we begin to facilitate avoidance, enable avoidance, if you will, which over the long haul really gives kids a difficult time. All right, so when I hear about an 8-year-old who's having problems falling asleep, middle of the night awakening and going to his parents' bedroom, I'm thinking what? Anxiety. When I hear about eating problems, they have 2 types, by the way. Mildly anxious kids overeat. That's me. Put me in an anxiety-provoking situation and I will pig out. Really anxious kids don't eat. They actually restrict. So when I see a vegan in a family of meat eaters, 8-year-old vegan, something's going on here with this guy. Something's going on with this guy. Avoidance of outside activities. We used to think that this was a condition that only presented at the end of August and early September. It presents every Monday morning after a weekend. Kids don't want to go back to school Monday morning. They're almost cured by Thursday and Friday, but then it starts up the following Monday again. You guys are nodding like you know what I'm talking about. That's very reassuring. The Monday after Thanksgiving, oh my goodness, the Monday after spring break, the Monday after the winter holidays, you name it, those days are really, really difficult. These kids don't go to camp. They don't do sleepovers. If they do sleepovers, you get a call at 11 or 11:30. I've asked families, okay, so when does he call when he tries to do a sleepover? Oh, it's somewhere between 11 and 11:10. How many times? We've done it 6 times now. The pattern is there around this avoidance stuff. They need excessive reassurance. These are the children who ask a million questions. What if this happens? What if that happens? What if it rains? What if it snows? What if it's too hot? What if it's too cold? What if the car doesn't work? What if you forget your keys? What if dad doesn't come home? What if mom doesn't come home? And you can answer them till you're blue in the face, and whatever happens, it doesn't really reassure them. The inattentive subtype of ADHD, people know what that is? Yep. That is indistinguishable from generalized anxiety disorder. And it goes like this. If you're inattentive chronically over time, you're going to get anxious. If you're anxious, you're going to be inattentive. So what I do with doctors, I say, well, take a look at your case logs, and if you look at your ADHD population and 40% of them are inattentive subtype, and you have no generally anxious kids in your clinic, given that the prevalence of generalized anxiety is probably 2 to 3 times that of the inattentive subtype, but everybody in your clinic's got the inattentive subtype, you probably have a diagnostic bias. You probably trained in one of those ADHD-oriented programs. You should have, in any clinical population, a good number of anxious kids. in your clinical population. If you don't, you probably are not picking it up, or you're misdiagnosing it as something else. It's not necessarily pervasive. So depression is pervasive, right? When you're 15, 16, 17 and you've got a depressive episode, that's all day, every day, 3, 4 weeks to month, 2 months in a row. It doesn't shift much. It's low and lower. Anxiety is a triggered affective illness. So if you put a kid in a safe bubble, he'll be very happy. But if you ask him to do something outside of that bubble, you will get the full affective experience. So I call it a triggered affective illness. It is a triggered mood disorder of the prepubertal child. So when you're thinking about depression in a prepubertal child, I don't think really about depression, because depression really doesn't hit until 14, 15. If a kid has affective disturbance prior to age 12, I tend to think about anxiety disorders, not depressive disorders. Oh, I got rid of one. Anxious children are tyrants. Absolutely tyrannical. Have any of you had an anxious boss? Are you done with it yet? When will you be done with it? When can I expect it? I mean, really. I know I told you I wanted it next week, but today, could you do it today? Do you have time today? You don't? Could you do it anyway today? That's an anxious boss. What happens is if you kind of begin to go like, or blow them off or push back against that, they raise the ante, right? Same thing happens with anxious kids. So when they stomp their foot, whine, moan, groan, they begin to up the ante, and eventually what happens is the parents capitulate to that. And as soon as they capitulate to that demand, they just reinforce the behavior that forced them to capitulate. Does that make sense? So if the kid stomps his foot and says, I need it now, and the parent says, okay, I'll give it to you now, you just set up the foot stomping. If the next day you want 2 foot stomps before you capitulate, now you've trained them to do 2 foot stomps. If they begin to get teary, and that's what makes you move the 3rd day, then all of a sudden they're trained to use tears. And guess what? The big thing in the 6 to 10-year-olds are explosive outbursts. Explosive outbursts are effective because they get parents' attention, and they get parents to pay attention to the need that the child has at that given time. So when I hear about the 6 or 7-year-old with rage attacks and bipolar disorder, I think, we got to look for anxiety in this kid, because anxious kids are tyrannical. Bipolar kids are too, but the prevalence of bipolar disorder between 6 and 10, the prevalence of anxiety as compared to bipolar disorder is about 20 to 1. So without ever seeing the kid, I'll be 95% right by saying it's anxiety in that age range rather than calling it bipolar, just because of the difference in prevalence. Does that make sense to people? Doctors think that way. We diagnose based on statistics. What's the commonest thing could be there that could be causing this presentation? And what I'm trying to say is anxiety is an extremely common condition prior to puberty, and we need to be alert because it's the time when kids have tic disorder onset. Okay. Oh, so I do family genetics. I want to know a lot about mom and dad. But you know, it's interesting. Sometimes they don't tell you they have a psychiatric history, or they haven't even gotten treatment. And so sometimes you have to ask mom about dad a little bit, and then ask dad about mom a little bit, and more about how they live. Because people who haven't sought treatment, they will understand how their loved ones live. And you can oftentimes hear in the background of how people live about these psychiatric disorders. Common things being common, we see a lot of naughty. See a lot of naughty in the Tourette syndrome clinic. And you know, we know how to prevent and treat naughty. It'd be very helpful. It makes a huge difference in day-to-day living if we can get kids on track in terms of good behavior control. You know, if you're a mom and a dad and you've got a kid with Tourette and you don't necessarily agree about how to manage that kid, oh my goodness, we see moms and dads have all kinds of trouble around kids with Tourette. You know, one of them likes to be tough and firm, and the other one likes to be loving and easy, and then they argue about tough and firm versus loving and easy, and they polarize from each other, and it can be very sad. Anxiety is extremely common, ADHD, depression. And I put the pervasive developmental disorders in there too, because those things in this population, simply because they're presenting clinically, are probably at higher rates than would normally be in the general population. These are some of the problematic assumptions that I've heard over time. He can't control it, gets generalized to he can't control anything. And as soon as we get to the place with a young child where we don't believe they have any capacity to control any thought, behavior, or emotion, we've really opened up that youngster to a set of problems over the long haul that's not good. I can't set limits on him. I don't know what a tic is and what's not a tic, so I question myself whether I can say he should stop that or not, because I don't want to say stop it to a tic, because I was told you can't say stop it to a tic, but I don't know if this is tic or not a tic, and I ask him if it's a tic or not, and he tells me, yeah. And I don't really trust him, so I'm not so sure about asking him anymore. I feel so guilty that I think I gave it to him or my grandfather gave it to him, and I can't set limits on him anymore. I mean, I just really want him to be happy. Meanwhile, he's running around extremely unhappy and out of control. Medication is the answer. Oh man, that med hunt. Families go on the med hunt, doctors go on the med hunt. What you see on TV and now YouTube is really not representative of what TS is. TS is generally a mild condition that gets better in the late teenage years. And then the other thing is really that we use this larger rubric of Tourette syndrome to define every kind of conceivable problem that kids have, when Tourette syndrome is really a neurologic condition that's complicated by psychiatric disorders. And that's really what it is. As I mentioned, TS kids are harder to parent. The rate of power struggles in a parent, in a family with a kid with Tourette is much higher than the rate of power struggles in other families. It's simply because these kids have a little bit more difficulty following directions because they have attentional problems, they have OCD, they're off track with their tics. And as a result of those power struggles, they develop maladaptive behaviors more quickly. And we don't see this much anymore. We do see this a bit, but there was a time where we were trying to take young kids with Tourette, make them advocates for themselves, and on some level kind of turn them into examples of outstanding Tourette-ness. The problem with that is that we've learned that from 15 to 20, their symptoms often get better. But if they've spent between 6 and 10 developing an identity as a person afflicted with Tourette syndrome, when their tics go away at age 15 or 16, they are not going to have the identity they need to go into adulthood. So what we're doing now is focusing on core elements of identity in a proactive way. So we have to understand what a child's endowment is, what they're good at and what they're not so good at. We focus a lot on family relationships because family essentially sets the structure in which kids are raised and how they turn out. We focus on academics. They don't have to be brilliant, but they have to show good effort and participate and kind of get the experience of working hard within an academic environment, because the basic work ethic gets developed academically, and that work ethic is the one that they're going to transition into adulthood and need. They have to have good peer relationships. I talk about kids learning how to blend and chill, because some of the kids with tic disorders don't blend very well, and they certainly don't chill very well, and it makes them stick out from their peer group, and they have troubles within their peer group. And lastly, and importantly, I want them to have good leisure activities. It's very common for kids nowadays to say, I'm bored, give me something to do. And I actually work with families to develop good leisure time management, because if kids have good leisure time management and they have a good work ethic, they begin to learn that if you work hard, you get to play hard too. Then you can work hard some more, and then you can play hard some more. And that, for me, is the recipe for lifelong success. People who work hard but also learn how to relax and take care of themselves at the same time. That identity can start extremely early, and if it persists in adulthood, those people will transition well into the academic environment and also transition well into the work environment. The other thing that we see with Tourette sometimes, I heard one lady talking this morning about how people are still getting diagnosed for the first time at 55, 60 years of age, 45, 50 years of age. I think it's important for clinicians who see adults to know that their experience of what Tourette syndrome was from childhood versus what a current 8-year-old's experience of what Tourette is vastly different. So we tend to see in that 40 to 70-year-old age group people who have had terrible treatments, have been discriminated against pretty heavily, haven't really known what their condition was. They've been told that their condition was one thing and it really wasn't. And so when they come to diagnosis, they have to kind of redo their thinking about who they are at a time in their life when they should really have a consolidated identity and sense of who they are. So there can sometimes be a fair amount of bitterness in this population that clinicians need to pay attention to. The kids who are between 25 and 40, this was a group, this is when I trained actually. Our job then was to get them on enough haloperidol to make all the tics go away. Now, the fact that they never woke up or could never really concentrate and focus in school was really not our problem. I'm joking a little bit, but this was a generation of kids who got over-medicated, heavily over-medicated to pursue tic suppression. There's another group, slightly younger group. This is the group that grew up in the era when, you know, you can't control your tics, therefore you can't control anything. What we tell kids now is you can't control your tics, therefore you have to do really well controlling everything else. Because you're going to have to be smarter, more disciplined, more in control of those things you can control, because you have this little chink in your armor. There's a little thing that's going to make it harder for you to be successful in life. And so if you're really going to reach your full potential, you've got to find a way to live life in a particular way better than people who don't have tic disorder. What we're saying now and have been saying for a while, it may be TS, but tics are not the biggest issue. That's a transition, if you will, but that's about 10 years old. And now really what we're saying is your outcome is associated with the severity of your co-occurring conditions and your self-control and the courage to overcome adversity. This, for me, is the positive vision about kids and adults with Tourette syndrome. It is, yep, you got a problem, but you know what? Let's manage those co-occurring conditions. Let's get you in the right place and facilitate mastery of everything that you possibly can master. Peer relationships, academics, leisure activities, family relationships. And you know what? If you show some pluck and courage in the face of some of this difficulty, that's not a bad thing either. Like I said, other problems that we see in this group, explosive anger. The reason why anger really turns into a problem over time is because, guess what? Anger works. Doggone it, I didn't get a raise last year, and I think I ought to get one this year. All right, we're going to give raises out this year. You know, we know people. Oh, good. So next year comes, doggone it. Anger works. Anger works. It is easily conditioned. It's also associated with mood and anxiety disorders. There's a new paper that just came out that said it was associated with tic severity. So the worse your tics are, the more vulnerable you are to this stuff. But that was in the context of worse ADHD. And I think it's also quite cultural. The World Wrestling Federation. And what is this total combat boxing, or what do they call that now? I don't know. We have in our culture a large emphasis on, if you're mad, letting somebody know that you're mad. We really don't want people to bottle up that feeling. Trust me, you really do want them to bottle that up. You want them to be civil, well-controlled, clear in their expression, understanding who's who and what's what, and not to just learn to unload. But we can facilitate that unloading in our interpersonal relationships, or we can really work with young people to find ways to manage their anger and upset feelings in a positive way. Treatment. Lumpers and splitters. What does that mean? Well, I'm going to talk a little bit about lumpers and splitters. Talk a little bit about tic suppression, comorbid conditions. I talk a little bit at the end about how to raise a child with Tourette. And I'm not going to spend much time here because there's no research base for this. It is absolutely stunning to me that we have not really figured out a way to take an adult with Tourette who's been struggling, you know, that 20 to 40-year-old adult who may have gone through a period of time where they didn't get optimal treatment, and figure out ways to get them back into school or get them employed again. We have not really done what we've needed to do with the adult population with tic disorders. Many of them have gone on to do pretty well on their own. Their families have utilized resources, but there still are some folks who are impaired over a lifetime from this condition and really haven't gotten the kind of research interest or support that they deserve. Okay, so here's what splitters do. The splitters make a list of problems. They rank them in order of impairment. They treat in the order of impairment. And they use the treatments that are specific to each problem. And this, we talked a little bit about this. If you have a kid who has Tourette syndrome and bipolar disorder and he's 19 years of age and you're seeing a Tourette syndrome doctor, oh my gosh, you are barking up the wrong tree. You need a doctor who treats mood disorders. It's time to give up that childhood diagnosis thing and move on to somebody who has expertise for the problem at hand. So that's what splitters do. They focus on what's the big problem and they make sure that people get access to the right docs and the right treatments. So if you have OCD, behavior problems, and tics, you're going to get cognitive behavioral treatment or meds for your OCD. You're going to get parent behavior management training for the behavior problems. For tics, you're going to get no treatment, wait and see, or maybe behavioral treatment nowadays, or clonidine or guanfacine, for example. That's a splitter's treatment plan. Identifies the constituent components and develops treatments, the evidence-based treatments for each of those components. What lumpers do is they say Tourette syndrome is the overarching disorder, that all of these problems that we've described, it's just all related to Tourette, and it's the Tourette thing that drives it all. And there is some tendency to say, in that context, let's treat the tics first and see what happens to everything else. Maybe we'll get lucky and all that other stuff will go away. Now, I like lumpers. Lumpers have a simple, clear understanding of what Tourette is, and most families like lumpers. And the reason they like lumpers is because when they go to school and the school teacher says, well, what's going on? And you say, well, he's got Tourette syndrome, he's got ADHD, he's got a learning disability in math, he has dysgraphia, he has OCD, he had a period of time where he had separation anxiety, and we just got a diagnosis of depression. The teachers glaze, they don't quite know what to do. So a splitter diagnostic description doesn't work very well for families. They want to go to the school and say, he's got TS, and just kind of be done with it. But doing that from a treatment point of view doesn't work very well. Being a splitter on the treatment side and understanding these constituent components is really helpful for longer-term outcome. I break actually medications for tic up into small, medium, and large. So clonidine and guanfacine are short-acting, although there are some longer-acting forms now which are probably better simply because they last longer. I call them small because a small number of kids have small amount of benefit. And I tend not to use small amount of benefit for a small number of kids medicines. I'm taught to do no harm, but I also want to do some good. And so if I'm exposing kids to medicine where there's a small chance that they're actually going to have a good-sized benefit from it, I tend not to do that. I feel like I maybe have 1 or 2 failed treatment trials in my relationship with a family. And if I accumulate 2 or 3 failed treatment trials, medication treatment trials, those families are going to begin to look for another doctor. The other thing is failed treatment trials adds to demoralization. If you think it's bad enough to have a tic disorder, just wait till you have a tic disorder that doesn't respond to treatment. Those families really, really have trouble. So I am very judicious about the medicines because I want to pick winners and I want to get winners. I want kids to be able to get better under my care, and I want the family to have an optimistic experience moving forward. 2 studies, an anxiety disorder study and a teen depression study. Are you ready? In both trials, the kids who got better pursued treatment after the trial was over. That treatment and additional treatment. The kids who didn't get better didn't pursue treatment. Wouldn't you think if you didn't get better, you'd go try and find something else? No, you get demoralized. So doctors, we have to get people better. If we don't get them better, then what they do is they get demoralized in their interaction with us, and we now have to not just treat the condition, but we have to remoralize people to get them ready to try again. That's a psychological treatment that takes a lot of work. I would much rather pick winners and have good success right off the bat because I'm using medicines that have high rates of good success. Tricyclic antidepressants, benzodiazepines, nobody really uses those much. But they have demonstrated improvements in tics. It's probably because both of those medicines decrease anxiety, and decrease in anxiety could be associated with decrease in tics. This is the old antipsychotics and new antipsychotics. They're kind of rank ordered. What do they used to say about 45 music about what do they used to say about records that it's number 2 in a rocket? Aripiprazole is a rocket. It is jumping to the top of the list, even though there's not a whole lot of evidence out there. The other one that's kind of rocketing is tetrabenazine. It's much more expensive, it's harder to get to, but you're seeing more people try that. On the old antipsychotics, we still kind of like them. They don't have as much weight gain, and especially if you use pimozide, much less sedation. They can make people stiffer, but they don't have the weight gain that you see with the ones on the right side of the screen. In Europe, they use sulpiride, tiopride, and tetrabenazine. Sulpiride and tiopride will probably never be available here. They're old medicines, and there's probably no interest among pharmaceutical companies to bring them over. Botulinum toxin. Before I went to New York, I only thought about botulinum toxin for dystonia and tics. Once I got to New York, I began to understand that botulinum toxin was used to fix wrinkles and other kinds of things within people's face. There's a lot of that in Arizona, too. The magazine, I mean, how many? Anyway, it can be useful for tics. It really works good when there's a single muscle involved, and that muscle contracts kind of chronically like that. Then you can offer a mild paralysis to that muscle that allows that head to be straighter and kind of held up. It's reversible, but it may not be reversible for 2 to 3 months. So you got to be careful about how much you give because you don't want to overdo it. Some of the early attempts to cure blinking with it resulted in people having a lid lag that lasted for an extended period of time. So you need a real pro to do this. It also has been used for coprolalia or other loud vocal tics. Why that would necessarily work, but it's been injected into vocal cords. And usually it's associated with a change in intonation. So if you're at the national meeting of the Tourette Syndrome Association, there's usually somebody there who's had Botox to their vocal cords. And I've seen these guys year after year. I have great friendships with people at the national meeting, and they're talking normally 1 year, and then 2 years later when you see them again, all of a sudden they got the gravelly voice, and it was the Botox. Ablative surgery. This is where you go in and do a little zzz, knock out a little brain region. Usually that was done for OCD, but because OCD and tics kind of travel together, there are some case reports of people where it was done for OCD and it looked at what happened with the tics, and as you can see, the results are mixed. Deep brain stimulation is hot. Is anything happening here in deep brain stimulation? You're beginning to see it? Yep. There's a bunch in your handout about exactly what that is, and I don't think I'm going to go through this in any great detail, other than to say that it's got great utility for childhood dystonia. While I've been teasing about YouTube, if you really want to see something extremely interesting, do DBS childhood dystonia and look at videos of children, adolescents who have had horrible dystonia. That's where your muscles contract and hold you into a position that's extremely uncomfortable, and what treatment looks like over a 6 to 9 month period. First video I saw was a young lady whose feet had turned under with dystonia, so that her walking surfaces were actually this part of her feet. And of course she couldn't walk because it was extremely painful. And 9 months later, they showed her, it takes that much time for all of that loosening to occur with deep brain stimulation. She was walking without assistance. She had a beautiful little lilt in her gait. It wasn't as smooth a gait, but she was not in anywhere near as much pain and was able to kind of plant both feet on the ground. When you see some magnificent transformation, or if you look at the Parkinson's video, and you look at what people are like with severe Parkinson's on that video and see what happens after they get DBS, you will see why surgeons and neurologists and others are very excited about what deep brain stimulation may do. I encourage you to look at some of the Tourette syndrome cases that are on the video, because some of those cases don't look like typical Tourette to me. So one of the things I think we're coming to understand is, like, with any medical condition, there are people who minimize their symptoms and there are people who elaborate their symptoms. And so why wouldn't we expect in Tourette syndrome that there are people who minimize their symptoms, and why wouldn't we expect that there would be people who would elaborate their symptoms? So if you look at some of the cases of DBS that have been done on YouTube video, make up your own mind about kind of what kind of Tourette that was. Some of them are pretty complicated and wouldn't necessarily, I think, get diagnosed by experts as actually having Tourette syndrome, yet that was the reason for the surgery. This is what it looks like. This is the stimulator, and that's the lead that goes in the brain. Usually people get 2 leads, one on each side, but I think people are increasingly interested in more complicated positioning. There are a few patients who have 2 for the motor disturbance and 2 for the OCD affective disturbance, so they have 4 leads in. These things are quite expensive. It's interesting, we've heard some folks now who have gotten these put in, but when they need battery replacements, they haven't been able to afford the battery replacement, which is $10,000 to $15,000. So in ladies, this gets implanted in the abdomen or kind of under the arm for cosmetic purposes. So this has miracle stuff on it, but we just have to be extremely careful about who we offer our miracles to, because it's not just today, right? If you do it in a 15 or 16-year-old kid and their tic disorder is going to get better over the next 3 or 4 years anyway, just have to think about it. I got a whole bunch in there. And I'm trying to stay on time because we're getting close to a break. So let me just say why we have to be careful with Tourette. This has a very young age of onset, but so does childhood dystonia. You'll see kids 7, 8, or 9 with severe dystonia. It is not a progressive disease like dystonia is. It's one that tends to get better with time. It's highly comorbid with psychiatric disorders, and those psychiatric disorders can affect tic impairment and severity. Tics are exquisitely sensitive to environmental factors. You'll hear a little bit more about that. So, you know, if you have a kid in an environment that's not all that helpful to them around their tic severity, you may be working on something with DBS that might be better treated with an environmental change. I mean, you all know that if you have a kid who's in a classroom where the teacher is angry and harsh and critical, you can make Tourette pretty bad. You certainly wouldn't want to do a procedure like this for that kid's tics because of that teacher. You'd want to do some other kind of intervention. And I think the other thing is that we see people with bad Tourette who are living happy and productive lives, and we see people with mild Tourette who are really, really struggling with living. And so in that case, who do you decide to treat? Do you treat the person with severe Tourette who's actually doing pretty well, or do you treat the mild Tourette for Tourette even though their impairment and other difficulties are in other domains? Those kinds of decision makings are very difficult. The Italian group is my favorite group because they only do surgery on people they know extremely well. What's happening in the United States is kids and families are going to centers that are doing this and are being operated on by teams of neurologists and psychiatrists and neurosurgeons who don't know the patient well. So you're more likely then to see a presentation of severe something and then operate on that severe something, and not really knowing that patient and their circumstances very well. And I think that's where, especially if we're under 18, we're working on that group of patients, that's where I get a little bit more worried about, is this the right treatment for this patient at this time? So this is that study from Italy. They're now up to 30 or something like that. They're continuing to do it. They are moving down in their age group, so they're down to 16 or 17 because some of these kids are at that period of time where it's supposed to be getting better, but they're still severely impaired. Their complications from this, believe it or not, are not that terrible. When it first came out, we were told that they can't remove the leads, but they've actually now gone in and put leads in, and they've also figured out ways to take them out, so if people don't want them or they don't work, they can actually remove the apparatus over time. But it's still a surgical procedure. Ooh, I'll save this one. Complementary and alternative interventions. So I think we'll take a break for 15. There's going to be just a couple of words from folks here, and then we'll come back with complementary and alternative.